I can start. So I'm from the Community Health and Wellness Department at Esperanza Health Center. So Maryann and I serve on the same team. And our team is basically, the task is to kind of be the eyes and the ears and sometimes the hands and the feet of Esperanza as we mobilize into community. We think about preventative measures to take. Maybe it's a program for families and such. So maybe it's fresh produce market. I mean, it's a random things. I mean, you come into our office, you wonder what we're about. So it's not clinical in that sense. As a traditional kind of like medical model. And so when this hit, we were kind of thinking about, we had grants, we had programs we were actually in program, community programming. We had a CSTAT, we have seniors program, we CSTAT. We had grants to actually propel us to do programming. We had to rethink that. And so the challenge was on. And the way I like to look at things sometimes is through kind of like, if I could read some scripture, is just to think about our department and how does it really function on the ground. And so from Romans 12, you're probably very acquainted with this passage, but it says, don't think you are better than you really are. Be honest in your evaluation of yourselves. Just as our bodies have many parts and each part has a special function, so it is with Christ's body. We are many parts of one body, and we all belong to each other. And I think that has been kind of like a succinct way to say, how do we partner with others? We are not all in all. We are not better than we think of ourselves. We are not the church. We are not those organizations that are on the ground. And so I think being able to have a realistic evaluation of what our bandwidth is and how far can we go. I think the big part of that is actually being able to do things with others. It makes it a lot more fun. It makes it a lot more, you feel a little bit like you have, breath under your wings, air under your wings, that you can actually fly with others. And so that's been our mandate, is just trying to think about, like, how can we bring what we have and our skills and our skill sets and our people, but also think about who is on the ground, who's doing that great work, and how can we, kind of expand ourselves because we're doing it with others. And so that's some of our premise. And so when this hit, we were like, okay, there was organizations that were starting to come together, obviously through Zoom. One of them was Operation Neighbor Care Philly, and that was mostly in Honey Park, where pastors and nonprofits and residents, and we showed up at the table and started brainstorming, like, what do we need to do? And food seemed to be the biggest, like, first thing to do was food access. And so we kind of jumped on that in regards to our seniors program. So as being the most vulnerable population. And so the simple way, if some of you know that in Kensington, they do food. That's their thing. And so we're like, okay, instead of us trying to think we're a food pantry and we're a co-op and all that, let's just like lean into our partners and say, all right, what can you do? We need to get this food to our seniors. And so they started buying more food, packaging food, and then we would just go by and pick it up, and then we would be the ones to deliver to our seniors. We didn't want to give that up because we felt like they needed also the face-to-face. So we kind of take our team and divide and conquer. And then another one was Drexel, the School of Public Health, Latino Health Collective was formulated. And so we jumped on that and we said, okay, we need to know about what's happening in our city, what's happening amongst our Latino populations, African-American populations. And so that has been monthly, a great opportunity to hear about data, to hear about like where are things really moving? What are some warning signs? Why is this so difficult, for our people of color? And what are the inequities around that? Then we went into, the idea is like, for us, it's like to be present, be present, listen and hear, and you just don't know how God is going to take that. And so like, I don't even know. I feel like it's been 4 years, sitting with Rock Ministries and not knowing exactly where this thing is going. What are you doing? What are we doing? We met many a times with Craig, Pastor Craig. They had a nurse practitioner, Anne Marie. Didn't know what that would look like. And so we just kind of like were present, just listening and hearing their heart and knowing what our capacity is at the time. And feeling sometimes it was very, very slowly moving, and we didn't know. A lot of times it was almost embarrassing to go back to the table to know, like, hey, we haven't really moved the needle on any of this stuff, but we're present and we're going to continue being with you and praying. And then all of a sudden COVID hits, and voila, they have the people, they have the tent, they have a nurse practitioner, and they have relationship on the ground. And so then we're able to bring our strengths, and Maryann's being one of those as the coordinator of that whole operation. And then it just kind of like happens. And so I think if we hadn't done all of that work on the ground ahead of time, like for years, we kind of wouldn't have known each other. We wouldn't have known how to really bridge that gap. And I said it took like a crisis to make it all happen. After all the many conversations we had. And so those have been some of the tangible things that we still doing Zoom programming, virtual programming, with our seniors, doing bingo and games and parenting circles and, trying to still stay engaged with families through Zoom. It's not easy. That's where you really see your disparities, because you have people like, oh, we have a Chromebook, but we have no internet. And so trying to think about creative ways to do that. And I think it's just about, like, in my mind, it's more about like, how can we present? How can we, it's kind of like for a time such as this, and we've used that tagline a lot, but it's like, we've been kind of building relationship, having our ear to the ground, knowing what the need is, being present on a Zoom call, even if it's like after 5 o'clock and you're just done, because you just don't know where all those things lead. And I think that's been a bit of our ministry, is just having a ministry of presence and seeing what the Lord would unfold. So I'll kick it off to either Bryan or Maryann at this point, but that's been our response on the community level.
Yeah, thanks, Deborah. Maryann, do you want me to introduce sort of Esperanza, and then you can?
Yeah, I can follow you, since my piece will just go into the details about some specific population. So I think that makes sense.
Yeah, hello, all of you. I was thinking that might get to meet some of you face to face here in Esperanza. So I was looking around in our classroom and such, and but Laura,
this afternoon, they'll be there this afternoon.
Yeah. Okay. Well, welcome to Philly, those of you who aren't from Philly. And so there's a total of about 15 or so, Laura. Yeah. Okay. Great. Well, my name is Bryan Hollinger, and I'm the medical director here at Esperanza. And so I wanted to just give you a brief sense of how Esperanza has been responding to the COVID situation. You already have had an introduction to coronavirus through Dr. Chipman. Is that who the Woody Chipman is I'm seeing here on the screen?
No, that was Woody's my admin person. And you can meet him this afternoon too. Jerry Jacob, I'm not sure Jerry Jacob. Jerry.
Yeah, no, I don't.
Jerry's an ID attending at UPenn and did SMI, did he say 2005, I think.
Okay.
Yeah. So SMI alum who's now an infectious disease attending.
Okay. Yeah, and so you're all filled in at this point on coronavirus and on all the particulars, so I won't go into those things. But yeah, feel free to interject, ask questions. I'm going to make this just a little bit interactive anyway, if I can here. So yeah, this like everyone else just hit us out of the blue here, coming from March into hitting Esperanza in a big way. Well, I think we really didn't believe, I didn't think that this was going to hit us in any substantial way. we thought, well, there might be a few cases in some of the cities that serve as ports of inlet, maybe to Esperanza, and maybe it would be similar to other infectious outbreaks that we've seen that really haven't amounted to much of anything in the States. But I think that, that it's been very unfortunate, the degree to which this has impacted the U.S. and to a certain degree has really been preventable. So I have a lot of remorse for just how the situation has been handled in many scenarios here. But so we have started off just by tracking the numbers. I've been connecting in regularly with the CDC, with the Pennsylvania Department of Health, with also the Philadelphia Department of Health, tracking numbers and watching them rise in Philadelphia. And we have, in response to rising numbers, continued to make changes in what we do. We started off just asking people screening questions when they were coming in the door. Have you had any travel to China? Have you had any respiratory symptoms? And those answers were almost all no. And then we went on with business as usual. But that started to change in March. And the question about asking about travel to China became irrelevant as the illness became well seated here in first of all in New York and New Jersey and out in the Northwest, and then began to disseminate rapidly. And at that point, we very quickly, once cases started to go up in Philadelphia, we saw our first couple, 10 cases. But when that number started to go up exponentially, we really had to take some sudden action. And we, at that point, quickly went to a strategy of sending half of our staff home on a given day, where we worked every other day. We had a team A and a team B. And the point of that was if one section of our staff becomes infected and that infection gets transmitted to others in our staff, that we are going to want to preserve at least some ability to take care of patients. And so we would have another team that could kick in. And also around that time, we started shifting to doing a bunch of telehealth visits, which is really telehealth at Esperanza. Really, telehealth is something that you do for when you're living in a rural location, or when people are 100 miles away and you can't get to them. And so maybe you do telehealth. But I'd never thought about doing telehealth here at Esperanza. And we had never done anything like that before, and had to search, look and see what kinds of software and things were available to do that. But we pretty quickly moved into a modality of the folks that were home working on telehealth visits, those of us who were in their office, seeing patients in the office and having to triage people, make decisions collaboratively with people. Hey, is this a person that we really need to bring in today, or is this a person that we can check in with by phone? And doing our best to keep folks that were elderly and had lots of comorbidities, let them stay at home so that we could check in with them and bring in people that were really most need to be seen to the office. And so that's what we did back in March. And that was really radical. How do you send a bunch of staff home to work as well when they don't necessarily are docs? Yeah, we all had laptops, but not all of our support staff had laptops at home. Not everybody has good Wi-Fi connections. And so you had to cross a lot of those barriers to be able to provide good telehealth care. And we suddenly were being reimbursed paid by the insurers to see patients at home. To give patients a phone call, we were going to get paid for that. Only lawyers got paid to make phone calls, not doctors. That was crazy. So suddenly we were even getting paid to make phone calls. And the response of our patients was universally grateful. During this time, there's a lot of anxiety. People are stuck in their homes. They're hearing things on TV. They don't get a chance to interact with people they know. And I was always amazed at just, I've been at Esperanza for a lot of years, so the relationships are, years and decades in some cases. But when you got people on the phone, people are like, "Oh, I'm so glad to hear from you." And, and it was just, there was a therapeutic, just making that phone call, I think, was therapeutic for some people, because really there's not a lot of interaction, not a lot of things that you could do. You can't listen to anybody's heart. You can't check their blood pressure. You can't give them vaccines. You can ask them about their symptoms, and you can reconcile their medication lists and stuff, but there's a lot that you really can't do. But nonetheless, I think that a lot of this has been the valuable things. And so also in the office, then what are we going to do with patients in the office? Because we don't want to get people infected. We began by screening patients as they came in the door if some people had symptoms. So we would ask them about the COVID symptom questions, right? So first of all, it's cough and shortness of breath, cough or shortness of breath, right? And then any two of 6 more symptoms, right? I think of the systemic symptoms, so fever, chills, body aches, and there's 3 more symptoms that belong to your head. So headache, sore throat, and loss of taste or smell. So if you have any 2 of those last 6, or cough or shortness of breath, you test. You have the symptoms that are consistent with COVID, and it's an indication for testing. That's just a little quiz thrown in there. But it's not like you couldn't present with something else. We know people have stomach aches and diarrhea, but the symptoms that we're using that are most specific that we're using for testing criteria are those symptoms. So we would screen for those symptoms at the door. If people have those symptoms, we would divert those patients over to a testing area of the health center, what we called our RE area, or respiratory evaluation area. At Hunting Park, it was over to our gym. At Kensington and Allegheny, we had an undeveloped space in our new building at Kensington and Allegheny. Hope you guys get to see the bank building, the newly renovated bank building over there. It's pretty cool at K&A. So there's a space there that we could divert patients to. And over at 5th Street, there's a space that in the back of the office, we could bring people back a side sort of alleyway and bring them in there where we didn't have to expose the rest of patients. So the idea was, if patients had COVID symptoms, we could send them, we could see them with all our PPE in place. We could get them a test, a nasal swab, nasopharyngeal swab. And then patients that were coming into the office, we could tell them, hey, when you come in, you don't need to be worried that you're going to be exposed to somebody who's sick. We're purposely seeing the sick patients at another part of the office so that when you come in, we're going to do our best that we can to protect you. So that gave them some reassurance. And we would equip anyone coming into the office with a mask. All of our staff began wearing masks, not initially, but remember again that this country was a little slow on the draw with asking everybody to wear masks because of the concern about having enough for healthcare providers. And that's part of the reason why this thing got out of the bag. The cat got out of the bag early on. But we made the recommendation to have every one of our staff wear masks, and also made the recommendation that even as we're out in the community, we really needed to be wearing masks, even before the CDC got on board with that. So masks help make it safer. We've also tried to create more distancing in the waiting room. We have sort of roped off greater spaces from the counter to where people wait, so that people that are sitting behind the counter checking people in and such, doing referrals, aren't directly exposed to people. We've erected sneeze guards, these plexiglass plates to help protect people as well. And obviously doing sanitizing on a regular basis, wiping down the surfaces that are frequently touched, to all help prevent contagion, transmission. So mostly we think that a lot of that has been helpful. We've seen about 350 patients at Esperanza that have had COVID so far, a little bit more than that now. And we've screened probably 1,300, maybe 1,400, I think, total patients in all. We've had about 6 or 7 of our staff members that have been positive for COVID. And praise the Lord that virtually all of them have been mild cases, and they have recovered or are recovering. We have one scenario that there was probably a person-to-person transmission here at Esperanza between staff when people were not being careful to be using masks in the office, and they were working in the same office. So you're going to hear that over and over again. Please use your mask unless you're in a private space. Keep your mask on. It's really vital. So we have also created testing sites. So we have a special dispensation, if you will, from the feds. Normally, a federally qualified health center, that's what Esperanza is. We're a federally qualified health center. That means that we get subsidized extra payments from Medicaid and Medicare. We get higher payments from them based on our cost per patient. But there's a lot of different things obligations that we have include that are excellent, including having a board made up of community members, and we have to submit all kinds of different quality measures. In return, we get free. We actually have our medical liability, our professional liability is paid for by the federal government. You have to sue the federal government to sue Esperanza for malpractice. So that's one of the benefits we have. But also, we are not allowed to take care of anybody who is not an Esperanza patient. If we do, we don't have any liability coverage for them. And so what was new when COVID came along is they said, hey, this is a crisis, this is an emergency, we're going to relax certain requirements. In fact, we need you to help play a greater role in the community with COVID services, COVID-related services. And now we're going to let that down, and we're going to let you see, in fact, we want you to see others in the community that might not be your patients to provide COVID-related services. We're going to permit you to do testing in the community and evaluation of people who might be sick with COVID. So that permitted us to start a drive-up testing in Honey Park. So we have drive-up testing now that's been pretty busy lately, that includes non-patients. And then we have the collaboration with the Rock, with Rock Ministries that Maryann's going to tell you about shortly. So as things have, fortunately in Philadelphia, then let's see, I don't know if I can easily flip this to, I think I can share my screen here. Oh, maybe I can't. This is not Zoom. Can I share my screen, Laura? Maybe not.
I think you should have a present. It says the word present on your right at the bottom. If you pull up your bar, present now. So the bar that has the microphone and the video on it, you may have to hover over the bottom
to
get it to come up.
Back to find the window where you guys are again. That's not it. I've got too many other windows open on my computer. Ah, there you are.
And then hover over the present now. Hover over the bar, and that'll share your screen.
Okay. Thank you.
That should work.
All right. Let's see. Can you see a graphic here?
Yes.
All right.
Yes, we can. I can. Can everybody else see it?
I can. Yes, I see it.
Okay. So this is just positive tests. I'm going to just show you this graph. I'm not going to show you a bunch of data, but this is COVID positive tests in Philadelphia. And so you can see that very abruptly in mid-March, we started having this exponential increase in activity, and that peaked from one case a day to around 500 cases per day. There was a good month or so that we were seeing about 500 cases per day, starting around, I don't know, late April or so, though those cases started to go down as people began to diligently stay locked down, and as they began to wear masks consistently and such, and we're now around 100 cases per day. All right, so this was supposed to continue to go down, not stay at 100 cases per day. And our mayor said that if we continued to go down over a period of 4 weeks, that we would to the green phase, from red to yellow to green, and we did not continue to go down, and so we're sort of in a modified green because of this plateau here. We're still seeing 100 cases per day. Actually, it's gone up. It was around 100, and it's gone up to around 130 cases per day. That's where we're at now. And we're a little bit cautious about that, a little bit wary. Are we going to go back up again? Are we going to experience another surge like is being seen down in Florida and Texas and all? And so everybody really has to be careful. We have to continue to model mask wearing and really promote mask wearing, because we're in a delicate spot now. We really need those cases to continue to go down, but we're at risk for them to go up if people get let their guard down. All right, stop sharing and go back. Okay, are you back on the usual channel here again? All right. So cases are going down now. That's good news for you all, being in Philadelphia. But we're still seeing 100 cases per day and still diagnosing a handful per day at Esperanza. So no time to let down your guard again. I wanted to ask, this is the brief interactive part here. I wanted to ask you all here, what are, so there's an intersection here of two different issues. One has been the intersection or the COVID illness, obviously, and we all know since the racial injustice issues that have come up, and all of the demonstrations that have occurred, it's been brought to our attention that persons of color suffer more from COVID illness. And I wanted to ask you why. What are your thoughts about why persons? And I did actually prepare a couple of PowerPoints, but I don't think they got to my Dropbox. But the long story short is there's a disproportionately greater number of COVID cases, number of COVID hospitalizations, and number of COVID deaths among persons of color, persons that are African American, persons Latino, have way more cases than they should based on their numbers in the population in Philadelphia. Why? What's going on with that? Shoot off some reasons why that might be. Unmute yourself and shoot off some reasons.
Could have to do maybe with like the types of jobs that they have. Might be disproportionately like exposed in different ways, whether you're a bus driver or a garbage man, or Yep. Or working behind the supermarket checkout, right? Initially, supermarkets did not have things in place at all to protect their employees, and that person working behind the supermarket checkout, who's probably making little more than minimum wage, maybe, is exposed to literally hundreds of people going by them right in their face, taking their credit cards and their money and everything. And now when we go in the supermarket checkouts, we see some plexiglass barriers and stuff, but initially that was not there at all. So yeah, where you're employed and what you do, these essential workers that for whom, and it really bothers me, nobody drives by the supermarkets with the sirens blaring and the horns beeping to thank those supermarket workers. Those are essential workers. Those are heroes, right? But they drive by the hospitals. Yeah, that's nice. That's cool. But what about all the other
essential workers out there that don't get that kind of recognition. It ain't right. What are some other reasons why persons of color might have disproportionate rates of COVID and COVID-related death?
Maybe they live in tighter quarters or in multi-generational homes.
Yeah, exactly. With maybe lots of people in that home too, and their neighbors maybe are right on top of them, as opposed to spread out, with acres of land and such like that. So population density, right? That's an excellent one.
I think it can go back to obviously what more conversation is being centered around, that racism is a health crisis and it's a public health crisis. So at the end of the day, the comorbidities that people have stems from systemic racism. So the fact that someone has hypertension, you have to realize, why is hypertension even prevalent in like the African American community? And it's not because you're just born because you are more likely to have hypertension. It stems from other things that are in systemic racism, So I think it goes back to what are the comorbidities that these populations have, and then it goes back to why do they have that. So I think that's definitely like a conversation that is being talked about more, which is really good.
Yeah. That's great, Amanda. So why are rates of hypertension high? Why are rates of diabetes high? Why are rates of obesity higher? What are the dietary choices like, perhaps for persons of color, often that are available with less income, that don't have access to the same food choices and things like that. And one of the things that was raised for me, a question that was raised to me lately, is even after you control for higher rates of vascular disease and diabetes and other demographics, there's still a persistent worse tendency that persons of color have for these health issues. And what is it? And what does it mean to be a person of color? My son is quite dark skinned. We adopted him at 3 months of age, and just spending time talking with him, and how is it that persons of color every day experience much more stress than we do, that they sort of get used to, probably not even really concentrating on a daily basis, but a level of vigilance. My son is 20, African American appearance, and he says he doesn't think about it so much, but when he's in the store, he's constantly the one that's going to be suspected of potentially shoplifting. He's the one that when he's out in the car, he gets pulled over for driving while black. And these all these kinds of things. Just what kind of a toll does that take on somebody's health? Day after day after day after day. We know that stress takes a toll, right? Type A takes a toll on your health. What does it mean to just be a person who's constantly having to face those kinds of stresses every day as a person of color? That's something that I can't say I know or understand on any kind of personal basis, but we need to hear other people sharing. We need to hear Amanda. We need to hear more from you, learn more from you about these things. Thank you. Other ideas?
Yeah, to kind of segue off that, it being in a hypervigilant state all the time.
Yeah, that's a word.
Incredibly stressful. That's exactly what it is. And then also being exposed to other people who have had violence committed against them, or hearing their stories, is a type of post-traumatic stress exposure, or a trauma exposure that can lead to post-traumatic stress. So you've got the combination of daily hypervigilance, particularly when you're in the car, anytime you're outside the house, pretty much, daily hypervigilance plus traumatic stress or traumatic stress by proxy, as you hear your friends' stories. That combination is really I'm not surprised with things like difficulty sleeping, that kind of constant jittery state, anxiety. I'm not surprised at all that that there are health effects to that. It only makes sense that there are health effects to that.
Any other thoughts as to why persons of color might have higher incidences and death rates due to COVID?
Weren't some being in the beginning of all, I know more tests are available now, but weren't some stories and cases of people that died, like they were even not provided with the opportunity to be tested? Like some people would go to the hospital and they weren't even given the COVID test, and then they actually ended up having COVID when they did the autopsy, I think, or just different cases I think in the beginning were more prevalent. So I think sometimes it goes back to, I mean, this is like a different topic, but even like the high rate of Black women that die just giving birth, it's astronomical. So the fact that I think it's like a study that like half of like medical students think that Black people have like a higher pain tolerance, which is like kind of concerning that people in like that field can think that way. But it's almost like if someone complains like, hey, I'm in pain, hey, I feel this way, it's like they're not believed, and then they end up dying. So I think with COVID, I'm not really sure about what's happening right now, but I think in the beginning it could be like people were turned away from actually receiving the care that other people were receiving, and that could have inflated the proportion of like how many people were passing away. But like I said, I'm not really sure what's like current, because I know more tests are available, but I'm not really sure if that's playing a role now.
Yeah, I think those are always relevant factors. Less access to testing, and then perhaps different standards of care, if you will, based on color that happen along the way. There are other issues as well. So if you are a person of color, you're being told, hey, school's closed, we're going to do virtual school. What about what kind of family resources are there to be doing school at home? There's certainly the case that in many neighborhoods, there's not nearly the access to good Wi-Fi, that families don't necessarily have laptops at home. That more often the parents are going to be working, and so how do they be able to supervise virtual school at home, right? So all of this for the kids and the families is much harder, tends to be, and for persons of color than for families maybe that have more resources. So I think those are some really important things for us to keep in mind when we think about COVID, and we think about the death of George Floyd, and just the intersection of those two is really key. All right, I think that I want to turn it over here in just a minute to Maryann. Maybe one other comment.
I think Holly was trying to say something. Sorry.
I just have one quick mention, but you talked about, I think Channing mentioned the types of jobs people have to go to because they're essential workers, but also because you're an essential worker, you usually don't have a lot of money sometimes because you're taking these low-level jobs. And so the ability to take time off or feeling like you have to work through your job even when you're sick because you don't have that option. Like my son works at UPS, and he said, nobody takes time off because everybody has to be there. If they're not there, they'll lose their job. And so they have to show up. If they got sick, they wouldn't say it because they don't want to lose any days, and they might lose their position to somebody else.
Yeah. Amen.
And a lot of these lower level jobs don't have health insurance either.
Right. Yep.
I just want to jump in real quick. I was trying to get an about tailcoats. I think another one is just a distrust from the medical community. Just historically, the issues that the African American community or other communities, per se, has had with the medical community, whether being lied about things or given tests that weren't told about or whatever have you. So there's definitely that disconnect of trust.
Yeah.
So I think that helps.
Yeah, that's a key.
Even with now like recommendations of wear a mask or do this or eat, it's just that, you don't trust it.
And that's really where I think as you all become involved in healthcare, And certainly at Esperanza, what we've seen is just the value of long-term relationships with patients in primary care, because what do you develop there? Trust, right? So when people first come in and they see this white doctor, they're like, what is he, you know, what am I gonna, what's this gonna be like? And but over time, when they see that you're there for them and you cared about them, it's uncanny, just the levels of appreciation that will develop because of the relationships that you're going to develop with people. So I want to ask you as well, when all this COVID is over, are we going to return to business as usual, to life as usual? This is sort of when COVID is over, right? Hopefully that will happen when it's back. I don't know, but will we return to life as usual? And I just want to be asking, as has been asked of me, how will we learn a lesson? What does God want to teach us as a result of the things that we're going through right now, so that we never return to life as usual? I think we should not return to life as usual. Some people say, don't waste the pain. Okay, you hear that a lot in addiction recovery. Don't waste the pain. How can we not waste the pain here? What has been what's God been trying to teach us here? And one of the things, there's a book called Christ and Coronavirus, or something that John Piper put out. It's just a short book that I recommend to all of you. Where he challenged us. He said, God doesn't bring. This isn't about judgment and punishment for Christians, though there might be an aspect of that for the world in general. We don't really know. We can't really interpret what God's up to, but God does want to purify. He might not want to punish Christians, but he definitely wants to purify us. What is God wanting to do in your life? What's he wanting to do in my life? What does he want me to be repenting of? How does he want to change my own level of alertness and awareness to those around me? How does he want to increase my urgency that people should know Jesus? I laid we've only had about 3 or 4 patients from Esperanza that I'm aware of patients die. One of them was a very, very close patient of mine. Fortunately, she knew Jesus. But how does COVID increase our urgency for the gospel, right? Because, you know, the end of the world is coming. We don't know when. Judgment is coming. We don't know when. But how does all of this increase our urgency that people should know Jesus? So I'll leave you with that. Remember, you protect other people with your mask. Maybe that'll be the last thing I'll say. You protect other people with your mask. Keep wearing your mask. Maryann, tell us about what's happening, some fun stuff, and some great ministry happening from Rock Ministries.
Sure. So you heard from Deb that thanks to many discussions and this ongoing partnership that we've had with Rock Ministries, God opened a door for us to be able to use a tent that they have set up every winter for shelter for the homeless population in Kensington. We were able to use that to turn it into a testing site. It's sort of this, like God always takes like the little that we have that we're not really sure what to make of it, and he turns it into something beautiful. And I think that's a lesson that I've been learning really recently. Like, and as Deb was mentioning, the importance and the value of just showing up, being present in communities, bringing forth what you have, and God using it. And so, here we had like this partnership that we weren't really sure what it would come to, but faithful communications with Deb and others, and they approached us saying we want to help. We have this tent, and it's really the perfect facility to be able to be on the ground, have like a low barrier access to people to come and get tested. So initially we were hoping mostly to be targeting the unsheltered population, realizing that they have particular challenges with COVID. This is a pandemic that we were responding to by hand hygiene and sheltering at home. So what do you do when you have a population that doesn't have shelter, and you tell them in your responses to shelter at home? to stay home and tell them to wash their hands. Well, they don't have, sinks, and the city set up like portable bathrooms, but still, like, it's a particular, the pandemic provided particular challenges for this population. So we were hoping to particularly provide access to testing and further education for them. We haven't seen as many people come through from that population, but we have had some, but we've been able to care for multitudes of others, including the residents of the local area and others. So I think, Amy, you brought up a comment there on the chat about populations who are undocumented feeling particularly uncomfortable and scared to be accessing medical care. And we've had some folks come through who are undocumented, and we've heard comments, including at our other testing site, of folks who said, they came specifically to Esperanza because they felt they could trust us, and they could trust that their information would be safe. So we've been really blessed to be able to care for different populations, and it's been just a blessing to be on the ground right there, able to interact with people, and it's been a ministry opportunity as well. And that, so as people are going through the testing site, the last stop is a prayer station, and we've had various folks there at the prayer station, and it's been a blessing to be able to partner also with local pastors who sometimes will be at that station. And I mean, from what I've seen, I think the majority, maybe 90% or more, have been willing to have prayer, and we have some verses hanging up on the walls, and so folks through and getting tested, but then also receiving the love of Christ, and hopefully receiving the love of Christ through all of us as well. And so we start the session with prayer, and we end with prayer as well. So I think that's made the work that we're doing especially less special. And some other pieces that we've been addressing with the work there is trying to get folks who don't have shelter to isolation and quarantine facilities. So we've been working closely with the city to get folks who don't have shelter while they're waiting for the results, or if they come up positive, into the hotel downtown for housing. And that's been harder than expected. There's a lot of steps involved with it, but also what appears to be an ideal situation. You tell someone who doesn't have shelter, we have a hotel that you can stay in, isn't always as feasible an option as one would imagine. So for some, they don't qualify. They don't have, they have extensive medical issues or mental health issues. The facility downtown isn't a hospital, so they can't always, and they can't handle that. Or, we have trust issues, like I had one person who was like, oh no, I don't know the exact words he used, but there was this feeling that, I don't know where this is, where you I don't trust that this is going to be something that's good for me. You're trying to pull, even though it feels safe and wonderful, you're going to get meals and bed and all, but you're pulling someone away from the community that they know, and especially if you add also substance use issues. So there's definitely concerns for withdrawal, and the city was accommodating for that and helping people get access to medication-assisted treatment for those using opioids. So they would help people get it started on methadone or buprenorphine to help them get to treatment and recovery, but also so to prevent withdrawal. But still, those were barriers. So even, and it shows that sometimes what we think might be an easy solution, also there's so many levels. But there was one day that a patient did come back and said that he really appreciated the time he was able to spend there, and that it was a great facility. So those are some of the challenges that we've seen. And just also specifically with the substance use, population struggling with substance use disorder, that's a concern that we've been thinking of including at the health center, and how this is a population that's had, even deeper isolation. We're all going through some sort of isolation. We're not able to connect with family and friends as we're used to. But this is a population that suffered even in deeper isolation, who's in desperate need for support during recovery. And so we've been trying to be attentive to that and bringing them in more for in-person visits so that we can continue to provide that support that's so desperately needed for recovery. And then another layer of challenge is, that this was a population that doesn't always have access to phones, and so telehealth visits aren't always feasible. And then another challenge that we've seen with this population is, some need further behavioral health care or further inpatient care for their recovery. And there's been less access during this time as the health systems are trying to protect people from transmitting the virus. So these are all some challenges that we've been encountering with both our substance using population and our unsheltered population, and both at the health center and at the Rock, we're trying to care for these populations and everyone who God brings to our door.
Maryann, are you concluded your formal presentation?
Yes.
Okay. Any questions for anybody, for any of our panelists, Deborah, Maryann, or Bryan? And then we're going to hear from Maryann again shortly, in about 5 more minutes after we take a short break, on health disparities and social determinants of health. So.
I have a question. I was just wondering, you hear stories around the country about people having to pay for their tests, or having some sort of cost for it or getting billed for it. Are those just billing errors, or is testing, is it available for anyone if they qualify for the symptoms? And what's true for this particular area?
I believe that free testing is available, absolutely, for those who don't have insurance. I don't know how, if there's mechanisms for providing free testing and all over, as there should be. Certainly that's the case in Philadelphia. I think insurances get billed for testing, but there shouldn't be, I don't believe there should be additional payment that's being required of folks, particularly that are uninsured, during this time through the federal funding and things that's been made available. Maybe somebody else has more details on that.
Yeah, if I may, from what I heard and what I understand is that there's been people setting up clinics and tents all over the country and charging, and those are widely fake because, as you mentioned, it should be completely free through the federal government. But there's been people trying to take advantage and set up their own COVID testing to make $1 off of it. As horrible as that sounds, it's been multiple reports of that. So that's my understanding.
That's insane.
Yeah.
That sort of brings back to me the, in the midst of the demonstrations and the subsequent to George Floyd death, that the violence, the looting, the trashing of stores, has occurred, which is totally distracting people from and not being carried out by the same people who are rightfully wanting to represent this issue and make a statement about this issue. And there's other opportunists that are out there just seeing what they can gain from the situation, which is awful.